All right, welcome to Grand Rounds Special Topics, May 2024. We have the honor of having Dr. Lauren Garges talk to us about a new era of empowering women in postpartum recovery with expert physical therapy. Dr. Garges Dr. Garges earned her Doctor of Physical Therapy degree from Arcadia University. She is the director of the Pelvic Floor Rehab Program at St. Luke's University Health Network, and she's board certified in women's health physical therapy through the American Board of Physical Therapist Specialists, and holds additional certifications in pelvic floor physical therapy and obstetric physical therapy from the APTA Academy of Pelvic Health. Dr. Garges has presented on numerous pelvic health related topics to colleagues within the medical field as well as local community groups. She's contributed to articles about urinary incontinence, pelvic pain, and women's running for Runner's World magazine, Forbes.com, and Health.com. She considers it an honor to help her patients with sensitive musculoskeletal issues that are often dismissed. This is our statement of need. This is our designation statement. And the planners and presenters have nothing to disclose. And now, without further ado, I will turn it over to Dr. Garges.
Thanks, Steve. I will move on to my first slide here. So, what is this postpartum initiative? This is something that really was born from our patient population, as it has been requested numerous times over the years, and so many patients of ours in the world of pelvic health have said, why doesn't every woman do this after she gives birth? And I kept saying, I don't know, this really should happen. And then after thinking about it, and as we've grown our team over the years, we've realized we can actually do this, and we really should be doing this. So the idea of the postpartum initiative is it's really a change in the standard protocol to how postpartum treatment postpartum patients are being treated after they're given birth. And here at St. Luke's, when they attend their postpartum OB/GYN visit, they will be referred to physical therapy. The fourth trimester is a term that's used very often within the world of women's health, and it really was actually defined in April of 2018 by the American College of Gynecologists and Obstetricians. And the fourth trimester is considered the 12 weeks after a woman gives birth. They actually came up with what they called a revised committee opinion at this time. And the idea of this is really that this period of time is an important recovery period for women and really should be considered more of an ongoing process of recovery versus a single encounter. So that's really what we see. Oops, if I can get to the next slide. Right here. So really they had some very specific recommendations, and that included physical therapy as an important part of postpartum recovery. This would really be a new paradigm within the United States as far as recovery for postpartum patients, because that is not really standard of care right now. And you can see that right here. So when we look at how the United States compares to other nations in the world, we can really see the difference here. So for example, in the United Kingdom, this is evidence-based guidelines that are out there. So there's a ton of evidence to support this. And postpartum patients receive pelvic health assessments at multiple visits. In Germany, there is a multidisciplinary team, which includes OB/GYNs, doulas, lactation, and physical therapists, who provide daily home visits for the first 10 days after a woman gives birth. And then she is eligible for up to 16 additional visits for the first 2 months after delivery. In France, a comprehensive pelvic floor rehabilitation assessment is performed, and women who give a vaginal birth are eligible for 10 PT visits and up to 30 PT visits if they have a cesarean delivery. In the United States, current standard of care is one postpartum visit. That visit often encompasses a 15-minute session in which, if there were no complications, meaning it was a relatively standard vaginal delivery, the patient is not getting undressed, she is not being examined, and she is queried about postpartum depression and birth control. At that point, she's typically released for all activity. So you can really see how disparate it is between us and other developed nations right now as far as how postpartum patients are treated and, kind of monitored during this relatively fragile time of recovery. So should all patients be referred to physical therapy? And as a women's health physical therapist, I strongly believe this is a resounding yes. The reason for this is that OBGYN training does not include assessment of the musculoskeletal system. And certainly childbirth, while it is absolutely a medical event, it's also a very large musculoskeletal event. And as physical therapists, we are the appropriate experts to be assessing and helping to rehabilitate the musculoskeletal system. So how is this initiative going to kind of be implemented? The idea would be that when patients go to their OBGYN checkup, which at St. Luke's Health Network happens anywhere between 3 and 6 weeks postpartum, every patient will be receiving a referral to physical therapy. Those physical therapy sessions will typically occur one time a week, and those sessions will be one-on-one for 45 to 60 minutes. The patients will be seen by trained experts who are able to assess, evaluate, and train the postpartum female. Here at St. Luke's, we have 2 types of physical therapists who are currently able to see these types of patients. We have a pelvic floor team, and currently right now we have 27 clinicians on our pelvic floor team. And then we've also trained orthopedic physical therapists, of which we currently have 18, who are also able to assess this patient population. They will not be doing internal vaginal assessment. So if they find that to be potentially appropriate based on the findings of the patient or the concerns of the patient, they could refer that patient to a pelvic floor therapist within our network. But there is a lot that can be done from an orthopedic standpoint, and we'll talk about that as I go through some of the further slides here. Almost every woman who's given birth has 6 weeks after she's delivered circled on her calendar. This is kind of well known among postpartum patients as the time that they will likely be released for all activity from their GYN. And I have many friends and family members who've said to me, I can't wait to go back to my doctor to be cleared at 6 weeks. If you remember, that postpartum visit, as it currently stands, typically in the United States, does not involve a physical examination. And these patients are therefore being released based on a date on the calendar rather than an actual physical assessment of their individual readiness for return to activity. So where did this 6 weeks come from? Well, it really comes from physiology and the fact that we know that often tissue healing may well be complete by this 6-week period. We're talking the size of the uterus has gotten back to its prenatal size. The cervix has returned to its size and shape and support. And a lot of soft tissue structures are kind of back to where they should be, in quotes, on a normal typical healing timeline. However, what about the musculoskeletal system? What is happening to the muscles? Specifically, as a pelvic floor physical therapist, I think about what's happening of the muscle tone, the strength, the length, the endurance of the pelvic floor. Is it ready at 6 weeks to return to all activities? Depends. What about core stability and coordination? Again, undetermined until that is assessed. And what about postural control and trunk stability? Again, this is a very unique and individual thing. someone may have good postural control and good trunk stability at that 6-week period, but again, it's such an individual thing. This is why we really think it is important for all patients to be assessed at this time to prevent future orthopedic or musculoskeletal injuries down the road. If you think about it from a physical therapy perspective, a patient would not return to full-blown sport or activity 6 weeks after a major musculoskeletal event with no rehab. If we think about the nationwide average of cesarean deliveries, it's currently at about 30%. So approximately 1/3 of all women who give birth are undergoing major abdominal surgery. And those women are currently, as it stands, not being assessed. That's why this program is hopefully going to be implemented here. So, when we consider that that's a major event, we should be appropriately assessing that. I can't imagine a patient who would have a total knee replacement or shoulder arthroscopy and, not have physical therapy afterward, but these women are having major abdominal surgery and then actually being asked to care for not only themselves, but an infant on top of that. So, and really, regardless of delivery method, the body really goes through so much during pregnancy and delivery, which is why we think this is such a valuable thing to offer to our patients. So let's talk a little bit about actually what happens with recovering from delivery, from actually pregnancy and delivery. So there's 5 things I'm going to review here, and these are really probably the main things that would be assessed by physical therapy, and we have the ability to kind of treat and help our patients with. So number 1, really postural changes. Of course, this picture shows what happens during pregnancy. And this is often something that we will instruct our pregnant patients in correcting their posture to make sure they don't wind up with too much thoracic kyphosis or lumbar lordosis or diastasis recti or neck strain. We kind of talk about that, but realize that once a woman delivers and she has assumed a bit of a change in her alignment and posture over time, those postural changes don't just automatically go back. So we need to really be doing a lot to help women kind of resume neutral, kind of alignment and improved postural control. So some things we want to kind of keep in mind would be educating patients on feeding postures to make sure they don't wind up with neck, shoulder, carpal tunnel, and elbow issues. So, something as simple as making sure they're using pillow support and not just holding baby while they're feeding, whether it's breastfeeding or bottle feeding. We, in physical therapy, we absolutely do encourage the use of infant carriers to allow mom or dad to be able to do some activities around the house. But we like them to be kind of what you see in the picture here, kind of what we would consider a midline carrier, so that it evenly distributes the weight of the baby throughout the lower spine and pelvis. And the carrier that is shown here is actually good if we consider a hip development of the baby. You definitely want the baby's hips to be in a wide and abducted position so that they're really kind of seated nicely in a good open pack position for the joint, for the hip joint for the infant. So these, as they develop and grow a little bit, are great slings to be using. So, we talk about ergonomics and things like that with our patients. Another thing that we discuss with many of our patients is the idea that carrying infant car seats is not something new mothers should be doing. When we think about the stretched out abdominal area, the stretched out pelvic floor, those muscles likely lack some strength and tone. An infant carrier with an infant inside may weigh anywhere from 20 to 25 pounds. And the analogy that I often give my patients is, I wouldn't want you to pick up a 25-pound kettlebell and walk around Target right now with that. So we absolutely encourage these kind of lightweight universal strollers that can be helpful to help mom get some errands done if she has no one else to help her. And that way she's not actually putting additional strain on her body. We also would say, this can be something that if you can bring someone with you, that would be great as well. But there are times when mom has to carry a car seat. So we will also talk about ergonomics and how to get a car seat out of a car without straining their back or straining their arms, how to hold a car seat. So these are all typical things that would be taught and gone over in physical therapy. A lot of our patients tell us that the newborn is not so much of the concern, but a lot of times their toddlers are actually pretty needy when mom comes home with a new baby. So as I was preparing for this, I was looking up, just Googling, how should postpartum moms pick up their toddlers? So that was really the Google search term that I put in. It was pretty specific, and I came up with nothing. There is really nothing out there about how can a new mom protect her own body when picking up a toddler. So what I did come up with is what you see on the left side, and I know it's hard to read, but I would say really this is what most of us as physical therapists often see, right? How to safely pick up something heavy like a 3-year-old or a 2-year-old, with typical recommendations of make sure you bring yourself down low, bring the child against you, bend your knees, don't bend with your back, very common things. But let's talk about the addition of a postpartum abdominal weakness there and pelvic floor weakness. What else should we be instructing new mothers when they may be picking up a 2-year-old? And the important thing that we absolutely have to instruct is proper breathing. And there's such a little out there. There was nothing that I found on Google related to this. This is why this kind of like one-on-one informational education can be very helpful in physical therapy. If you look at the slide on the right and we look at kind of the idea of what happens when you inhale, clearly, you inhale, your lungs inflate, your abdomen expands, right? So you have this increase in intra-abdominal pressure. When you exhale, the abdomen will engage. That would include the pelvic floor and the abdominal muscles, and the lungs deflate. So we kind of see this kind of drawing in action. So what we instruct new mothers when they're picking up toddlers is to exhale when they're doing so. The reason for that is it's going to shore up their deep internal core automatically, and that intra-abdominal pressure, instead of loading downward because of gravity against a weakened pelvic floor, it actually is expelled through the breath. So again, nothing out there that I can find with Google searches. If there's women researching this, how do I protect myself when I'm picking up my children? I didn't find anything. So I do think it's important that we kind of really, see these women one-on-one to instruct them in these breathing techniques and breathing strategies. I would say if there's one takeaway that a lot of our patients tell us, it is, I really learned how to breathe and protect my pelvic area during this. So, that during my PT. So it's an important thing that we talk about. Another very common finding is urinary incontinence, and one of the most recent studies that I found showed that about 47% of women do have concerns of urinary leakage in that first year of postpartum. There was a study in 2016 that was astounding to me. I just found this recently, but it shows that if women have urinary incontinence at 3 months postpartum, so that would be at the end of the 4th trimester, 76% of those women will continue to have urinary incontinence 12 years later. So this really speaks to the importance of capturing these patients in this important 4th trimester window. So if they are having urinary leakage in that first 3 months postpartum, that is such a valuable time to prevent future problems down the road. And urinary incontinence will often be kind of taken as almost like a rite of passage that can happen in midlife and later life among women, unfortunately, in our society. There's commercials on TV and, you just put a poise pad on and go down the slide with your grandchild and just live your life, when frankly, this is very preventable and very treatable. And it really has a negative impact on quality of life. It is the reason why 50% of people are admitted to nursing homes as well. So this absolutely can have a future impact in quality of life of people. So capturing patients early in this fourth trimester timeframe is critical. And then there was a Cochrane review about 5 years ago that showed that physical therapy treatment is 5 to 8 times more likely to eliminate urinary incontinence symptoms as compared to controls and as compared to pharmaceuticals. So we do find that muscle training and education can be very helpful. It's relatively easy to treat. It's considered often kind of normal, but it is not normal. And so that is something that is kind of a mantra that we as pelvic therapists often think. It may be normal, it may be common, but it is not normal. And we want to keep that in mind. So it's extremely treatable. I did a grand rounds presentation last week to our OBGYN department, and this was actually a slide that I showed them and said, you know, what might you say to a patient who presents to you with a complaint of stress urinary incontinence when they laugh or when they exercise? And, you know, so just if you just kind of pause and think about that, what might you think an OBGYN would say, or what might you say to a patient who may have this as a concern? The answer was not a surprise to me, and it is in fact what ACOG recommends. So the American College of Gynecology and Obstetricians and Gynecologists recommends Kegels. And I would say that may not always be the answer. So if we think about a patient who presents with a 0 out of 5 pelvic floor strength, which is not an unusual finding in a postpartum mother. If she's instructed to do Kegels, if we think about it from a musculoskeletal standpoint and as physical therapists, if they are a 0 out of 5 and they are sent out of the door to go home and do these exercises, how effective is that going to be? They are probably going to end up compensating with glutes, adductors, abdominals, quads. But if they're a 0 out of 5, they are not able to engage their pelvic floor, and they are very likely going to be compensating with the wrong muscles and therefore not appropriately strengthening their pelvic floor. Research shows 40% of women do not know how to do a Kegel exercise. That patient is one who presents with something that we would call more like a lax pelvic floor. And you can see that the analogy I might use with my patients is a droopy type of pelvic floor, like a hammock. But we also see patients who maybe not an early postpartum, but maybe a little bit later, say 6 months, 9 months, 1 year postpartum. They may come in and say, I am leaking, but I'm also experiencing some pain. And those patients also may not be appropriate for Kegel therapy, at least not in the beginning, because what we may find with them is their hammock of muscles, their pelvic floor may actually be too toned, too tight and tense. And if they do Kegels, they're actually worsening that tightness. So there is a very happy Goldilocks middle that we want women's pelvic floors to be. And that is really kind of a correctly toned pelvic floor that can engage and lift, but can also correctly release and relax. And this is where the skill set of physical therapy really comes in. So telling women to do Kegels, while it is recommended by ACOG, I think there needs to be a but and then a ... after that, because it really needs to be assessed to see, is that even appropriate? You know, what is this woman's pelvic floor doing? So it's a very common recommendation, and sometimes when patients come to see us, we have to really assess and see if that's even appropriate or not. Another common finding is DRA, diastasis recti abdominis, which is, you know, this picture kind of shows nicely. It's kind of a separation between the rectus abdominis muscles. So that linea alba, which is that connective tissue between the two muscle bellies, is stretched too far. It's the study that I found from 2016 shows that it's about 60% prevalent at 6 weeks. So that would be when a lot of women are going for their postpartum checkup with their doctor and hopefully coming to physical therapy. And that's not really too much of a surprise and actually too much of a concern. The real concern is 6 months and on. So research shows that if women have continued diastasis or continued gapping of this, the linea alba, after 6 months, that's when we lead into long-term dysfunction, back pain down the road, poor core stability, poor trunk stability, trouble with defecation mechanics, potential urinary incontinence, things like that. So the fact that 45% of women still have this at 6 months, which is really, in my mind, an important time frame, it's important to capture them before that to kind of work on this area. The concern is that it really is kind of like a gapping between those two muscle bellies with just really poor tensioning, and clearly that isn't great for intra-abdominal pressure management. There are numerous types of diastasis that exist. There's like the 4 most common on the bottom. I would say the most common that I see is kind of the one on the far left, what they would call an open diastasis, or maybe the second one from the right, that like above the navel diastasis, but it really doesn't matter. The reality is there's poor intra-abdominal management here. So this needs to be kind of like controlled, and we need to do some very specific exercises to help with this. There's a lot on the internet about this. Women often get concerned about like, oh, I saw on social media I should never do, planks, or I should never do sit-ups, and I really don't like to use the word never. Really what we need to do is kind of work into a movement if that's a goal of someone, and have them do it in a stepwise fashion to really kind of get to having good control there. We can see in this picture here, this is what we will often see, the picture on the left there, as far as, if someone has diastasis, this kind of gapping, we call it doming or coning, and you will see kind of that midline kind of protrude and actually literally kind of pop upward. So a lot of times, patients are told, you don't want to use your rectus muscles, don't do that, it might widen the gap. The gap is not really as much of a concern as it is the laxity that exists within that gap. So when we assess this, we are assessing, yes, the width, but we're also assessing the depth. And then we're also measuring how far it may be from the umbilicus, so kind of the length. And if I had to pick up which of those depth, width, or length is the most important, I'm going to say depth. You want good tension in that linea alba. So it's kind of like a suspension bridge. If you have a real saggy suspension bridge, those things are not really shored up well. But even if the bridge is wide apart, but you have a good bridge and good tensioning, that's actually kind of the goal we're looking for. You can see in this patient here, one of the ways that coning was controlled was by teaching them activation of their transverse abdominis and also proper breathing strategies together with engaging their pelvic floor. So when we think about the core muscles, pelvic floor, transverse abdominis, diaphragm, multifidus muscles, we actually train that entire core canister to turn on properly. That patient could then do a crunch and actually up into a sit-up without coning. But if she wasn't engaging her deep core first, we were seeing that kind of coning happen. And so this is what rehab looks like. We really try to teach them to strengthen from the inside out and get them back into all forms of exercise that they choose to do. So that's kind of how we go about rehabilitating the diastasis of that area of the body. This is another, kind of very specific thing that we treat in physical therapy. So among our 2 types of PTs, right, we've got an orthopedic track of postpartum physical therapist and then pelvic floor physical therapist that can treat this patient population. This would be more the pelvic floor team that would see patients who have painful sex. Dyspareunia is the medical term for that, and at 6 months postpartum, about 2/3 of women are describing this as a concern of theirs. 2 studies, in fact, a very recent systematic review of 19 studies found very clinically significant improvements in painful intercourse and quality of life with PT intervention. And I can speak to this. I've treated this condition for over 18 years. It is very treatable. It's under-discussed. It's not sent for physical therapy enough, in my opinion, and it is something that we can absolutely help women with. So an important quality of life thing to be considering as well. I didn't segue into this next topic very well. The slide's a little bit out of order, but we can talk about it. So this was yet another slide that I presented to the OBGYN department last week. And I said, if you are seeing a woman at her 6-week postpartum visit who is a runner and she wishes to do a half marathon in 6 months, what would your recommendations be? And by that time, I had spoken for about 35 minutes, and 2 people in the back said, I would send them for physical therapy. And I said, good answer. Like, that's right. Yeah. So happy to hear that. Really, this is something that returning to sport, returning to activity is super important, and a big question that a lot of patients come to us to see, because they do get cleared at 6 weeks and they're like, am I ready to play pickleball? Can I go back to CrossFit? You know, can I start running? Like, this just feels funny down here. I'm not sure if I'm ready. So a study came out last year that reviewed 33 different studies in the British Journal of Sports Medicine. And it was called Navigating the New Normal: What Guidelines Exist for Postpartum Return to Physical Activity in Sport. The findings were a little bit discouraging. Most studies found that return to sport in the postpartum period can begin once it's medically safe, around 6 weeks, because of that tissue healing that we already spoke about. But medically safe is not well defined at all in the literature. In addition, most studies of those 33 studies recommended that at 6 weeks postpartum, women are being recommended to do 150 minutes of moderate to vigorous physical activity at 6 weeks postpartum. But the type of exercise is nonspecific. And that made me pause, for sure, because I had 2 children, and I remember with my first baby going to my 6-week visit, and I was a runner prior to that pregnancy, and I had that on my radar as something that I wanted to return to. And at 6 weeks, I went to my visit. I don't remember much about it, other than I do know that at 6 weeks, I was breastfeeding my daughter every 3 hours around the clock. So day and night meant nothing, and I was absolutely exhausted. I do think that if my OBGYN at that time had said to me, I would like you to do 150 minutes of moderate to vigorous physical activity every week, I think I would have cried at 6 weeks postpartum. Those guidelines that exist very non-specifically, and those of us who are familiar with the American Heart Association probably know that those are based on American Heart Association guidelines. But pulling that out and putting it on top of a patient population who is fatigued, exhausted, underfed, emotionally, erratic, and really very just not quite themselves yet, putting that as a recommendation is very concerning to me. I would say that thankfully my doctor didn't tell me that at 6 weeks with my daughter, and I do remember her first birthday was in Chicago because I ran the Chicago Marathon when she turned 1, and at that marathon I qualified for the Boston Marathon, and so I did get back to running, and I was able to rehabilitate at an appropriate pace. But at 6 weeks, I was by no means ready to go back. So my point being, this is such an individual thing. So making it such a global recommendation, 6 weeks, you're ready to go back, and you should be doing 150 minutes of moderate to vigorous exercise. I do tend to pause on that and really think on that, and think this is really something that we as medical providers really need to kind of be a little bit judicious about. The conclusion of the study, I actually put it in quotes here: a lack of consistent evidence-based guidelines exist for return to activity or return to sport postpartum. Multiple evidence gaps require additional research to inform patient and activity-specific guidelines for safe and successful return to activity or sport in the postpartum period. If we think about this idea of returning to activity, really peak athletic performance does coincide with the peak fertility years. So as physical therapists, absolutely, I want my patients getting back to activity or starting activity if they're not doing anything already. So we absolutely encourage this, but we just need to consider the patient in front of us and the multifactorial things that go back into returning to an athletic endeavor. A study in 2009 found that during labor and delivery, the pelvic floor muscles stretch to 250% of their resting length. So if we think about kind of that, thinking back to like our, anatomy and physiology, think of length tension relationships when it comes to strength and endurance and muscle control. A very lax, stretched pelvic floor is probably not ready to go back to a lot of high endurance exercise or heavy impact. And a study in 2022 found that high impact exercise has a 5-fold increased risk of pelvic floor dysfunction as compared with low impact exercise. So what should our patients be doing? It's so individual. Return to sport readiness is unique to each individual and needs to be individually assessed. I have some patients who I think could return to running at maybe 6, 8, 10 weeks. That might be a little unusual, but there are some who I think certainly can. But again, it's such an individual thing. So if you are working with a postpartum patient and they have questions for you, I think these are kind of some nice things to just kind of to globally be aware of and maybe talk to your patient population about. So I put together a couple questions. For example, are they aware of their fluid and caloric needs? If a mother is breastfeeding, she will likely need about 300 more calories a day to account for what she's providing for her newborn. And as far as fluid intake, we would recommend half their body weight in ounces plus an additional 20 to 30% on top of that if they're returning to a sport in which they're going to be kind of perspiring and sweating. Something else I have them do is like kind of check balance and stability. Can you stand on one leg for 10 seconds? With this, we think about sporting activities, a lot of it is a single leg activity that's repeated really quickly. So we want to see what's that stability look like when you're just, standing on one leg 10 seconds. Can you stand on that leg without your pelvis dropping? So here we're looking at like core, trunk stability, hip strength, things like that. What about a partial squat? Can you do a squat without your knees rolling in? We want to consider what's happening with, again, hips and core control there. Can you lift your head and not have doming and coning occur? We want to, outroll that diastasis as a problem. What's your posture look like with walking, standing, even movement and shifting side to side things, kind of ballistic movements? I will look at that spine and posture during those activities as well. Do they know proper breathing strategies with exercise? So of course, exhale on exertion is something we want to train all of our patients to be aware of, especially in a postpartum mother who may already be at risk of some poor pressure management, mechanics within their weakened core. And are those patients free from pelvic pain, pelvic pressure, or incontinence? That last question, if they answer no to any of those three things, that is an appropriate patient to refer specifically to a pelvic floor therapist. But a lot of those other things that are on this list can very appropriately be treated by an orthopedic therapist, kind of just orthopedic physical therapy. This is what we do. This is what we're experts at. So that's really the summary of what I wanted to go over today. I would say that our team here at St. Luke's is awesome and honored to treat this patient population. It is a privilege to work with these women. Women's bodies are resilient and amazing, but sometimes they just need a little help to kind of make sure that they can continue to live long, healthy, strong lives. And we are thrilled to be able to offer those services to those patients here in our community. So I am happy to answer any questions that may be out there.
If you have any questions, please either unmute or type into the chat.
Therapy during pregnancy as well. The question is, do we recommend therapy during pregnancy? Oh, for sure. Some of the common things that we may see patients for during pregnancy, you know, many women think about low back pain, sciatic type pain. We see women for SI dysfunction, for pelvic pressure, for pubic bone pressure, those types of things. So yes, and that is something that you don't have to see your doctor for. You know, you can just kind of refer yourself, direct access here in Pennsylvania. For the most part, most of our team members can treat that, but for sure we see patients during pregnancy. When patients see us, they before they're discharged and have their baby, they actually at many of our offices already go ahead and schedule their postpartum physical therapy evaluation, knowing that, you know, we tend to develop a bond and they actually see the value in their physical therapist and the treatment that they've received. So we will have them schedule their postpartum visit or the postpartum exam based on their due date. So if someone's due, you know, the end of May, we will likely schedule it 4 weeks after their due date to come back in and see us for their postpartum therapy. Yeah, good question.
One person asked, are there different recommendations for returning to high impact exercise with C-section versus vaginal delivery?
That's a good question. Should I repeat that, Steve, or do people hear that? One of the questions was, is there a difference in returning to high impact exercise for cesarean delivery versus a vaginal delivery? Unfortunately, there is such a dearth of research on this. I can't say that I've seen good evidence one way or the other. I do think certainly we need to be mindful that a cesarean may take anywhere from like 3 to 4 months for that that scar to really heal well. So it depends on a variety of factors and what the sport of choice would be. We do recommend abdominal binders for all of our cesarean patients. And in fact, I just found out that all women that deliver at St. Luke's do go home from the hospital with a binder after they've had a cesarean section. And that really, it's interesting. You know, I've been a therapist for quite a while. So when I was trained, we were taught to get them out of any type of external support as quickly as possible. But my mind has really shifted in that regard. I do think it really can help to kind of give them some good postural, actually a little bit of postural cueing and some support along that weakened core. And then if we teach them proper breath strategies and things along that way, when it comes to activity, even just daily activities, that can be really helpful. So again, the answer is it depends, and it probably is very individualized. But I don't see any reason why a woman who has a cesarean cannot return to high impact sport for sure. But she would probably need to be assessed and kind of see like what's sensation like. Like a lot of times there's numbness along that scar for a good 6-9 months. And then numbness doesn't prevent necessarily return to activity, but it can sometimes affect the ability of a woman to really properly engage her TA. Or to at least feel that happening. And so, you know, we kind of want to be mindful of a variety of factors in that way. And the fact that she's delivered via surgery doesn't negate the fact that she was pregnant for 9 months as well. So I think a lot of women don't realize that their pelvic floor musculature is going to be at a deficit after a cesarean as well, which is kind of a bummer. You didn't deliver vaginally, but you still have some deficits there. So we need to work on pelvic floor muscles as well, even if they've had a cesarean.
Any other questions? Well, thank you very much. And please make sure that you sign in and that you complete the quiz and course evaluation to get CE or CME credit for this course. If you have any further questions, please feel free to reach out to Dr. Garges, and thank you very much.
Thank you.